Dear friends, in this video, I'm going to talk about autoimmune diseases in the ICU and what intensivists should know if they come across autoimmune diseases. Let us start with this case. A 55-year-old male presented with complaints of diffuse bone pain, fever, and loss of appetite for 7 days. He had history of worsening fatigue with dyspnea on exertion and occasional palpitations for a period of 1 month. There was no alcohol abuse history. There was no history of any smoking history or tobacco use or any illicit substance use. There was also no visible rash anywhere on the skin. On examination, patient was conscious, oriented. Blood pressure was 110/60. Heart rate was 124 beats per minute. Respiratory rate 24. And temperature was 100.4 degree Fahrenheit. On local examination, patient had multiple lymph nodes of varying sizes, which were non-tender and distributed unevenly in the anterior and posterior cervical chains, that is in the neck, as well as in the submandibular and supraclavicular regions. In investigations, the patient was anemic. The hemoglobin was 7.2, also leukopenic. The WBC count was 3000. Hematocrit was 24%. Platelets were normal. ESR was very high, 100. Ferritin level was 1000. LDH was 300, although SGOT-PT was normal. The peripheral blood smear showed poikilocytosis, microcytosis, and thrombocytosis. On rheumatology workup, the patient was positive for anti-nuclear antibody, dsDNA antibody, and anti-smooth muscle antibody. Now, if we come across such a patient, then definitely one should suspect for autoimmune diseases. But there can be reasons to suspect autoimmune disease even before that. Most of the time, autoimmune diseases will have manifestations which can be clearly observed in the clinical setting in either of these organs. In skin, there can be skin rash, which is common in SLE and dermatomyositis. Photosensitivity is common in SLE. Alopecia can be there in SLE, dermatomyositis, and in Graves' disease. Sometimes in the heart, there can be cardiogenic shock in SLE, antiphospholipid syndrome, myositis. There can be tamponade in mixed connective tissue disease, SLE, rheumatoid arthritis. There can be endocarditis or valvular diseases in certain conditions, as well as there can be venous thromboembolism or thrombo episodes with pulmonary hypertension in some cases. In addition, there can be vascular changes in the peripheral vessels leading to Raynaud's phenomenon. There can be myositis. There can be inflammation of the joints leading to bone pain. And also there can be involvement of the brain leading to stroke, seizures, aseptic meningitis, delirium, etc., more of which are seen in SLE. In the lungs, there can be interstitial lung disease, pleural effusion, or diffuse alveolar hemorrhage in certain conditions. The kidneys may get affected on account of glomerulonephritis, thrombosis of the vessels, scleroderma renal crisis, tubulointerstitial nephritis, and so on. Livedo reticularis may be present, as well as there can be changes in the blood leading to anemia, hemolysis, thrombocytopenia, and coagulation abnormalities. So whenever there is a combination of these findings or clinical manifestations, one should suspect autoimmune disease, because autoimmune diseases are heterogeneous inflammatory disorders which may range from organ-specific involvement to multi-system disorders which can be responsible for multi-organ failure. Most of the autoimmune diseases are either systemic or organ-specific. When they are systemic, the autoantigen is present all over the body and autoimmune reaction is mediated by autoantibodies. The examples include rheumatoid arthritis, SLE, cryoglobulinemia, antiphospholipid syndrome, microscopic angiitis, etc. When they are organ-specific, then the autoantigens are organ, tissues, or cell-specific, and autoimmune reactions are mediated by the T cells and autoantibodies, and that includes Graves' disease, myasthenia gravis, type 1 diabetes, multiple sclerosis, neonatal lupus, etc. But it is important to also to remember that up to 10% of the patients would require admission to the ICU either because of the disease flare-ups or infections. These infections may be secondary to their immunosuppressive treatment, or they can be admitted due to acute organ failures. So then what are the major concerns for the autoimmune diseases in the ICU? One, we have to identify the disease flare early, because in the context of unexplained or unusual clinical presentation, if we are able to identify them early, we can avoid end organ failures and thereby prevent mortality. So this is the most important concern. Next, it is to provide immunosuppressive treatment along with life-sustaining therapies, which are very important in autoimmune diseases because the antibodies do not recognize the self antigens and therefore they cause harm to the own self. Third concern is to identify and manage severe adverse events of immunosuppressive therapies, mainly infection, which are sometimes difficult to distinguish from the underlying disease exacerbation because of some kind of mixed presentation. But it is very important also to remember that 5 clinical situations should not be forgotten and should be particularly aware of, which includes scleroderma crisis, pulmonary renal syndrome, acute interstitial lung disease, which is connective tissue related, acute severe cytopenia, as well as catastrophic antiphospholipid syndrome. Now let us see what each of these are in a very short way, crisp manner. In scleroderma crisis, there can be 2 manifestations. One, scleroderma renal crisis, where the patient presents with malignant hypertension and oliguuric acute kidney injury. This is followed by left ventricular insufficiency and hypertensive encephalopathy. So they may finally culminate into, if the patient presents with encephalopathy and coma. This is more frequent in patients receiving steroids and can be triggered by nephrotoxic drugs or due to volume depletion. In such cases, the mainstay of the treatment is aggressive blood pressure control by using the ACE inhibitors and also the calcium channel blockers if required. However, beta blockers should be avoided because the beta blockers may exacerbate Raynaud's phenomenon. So that may be manifest in course of the illness. And such patients, because of their kidney involvement, frequently require dialysis. The other manifestation in scleroderma crisis is scleroderma cardiac crisis, which is distinct from scleroderma renal crisis, which is uncommon, but it is life-threatening complication. And particularly, it can occur in patients with recent onset and who have a vascular phenotype. So this vascular phenotype can be diagnosed by doing the genotyping. And this scleroderma cardiac crisis is manifested or characterized by acute left ventricular dysfunction, although which is usually reversible initially, but later on leads to poor long-term outcomes because multi-organ failure sets in. And patients with scleroderma are prone to life-threatening complications, which can be non-scleroderma related causes or respiratory complications. So this is one condition which has to be particularly suspected and identified in patients who have scleroderma or risk for scleroderma when they present with such manifestations. The second important concern or the second important clinical manifestation which needs to be identified is the pulmonary renal syndrome. In pulmonary renal syndrome, usually the patient presents with diffuse alveolar hemorrhage, which is suspected usually in the simple chest X-ray, followed by bronchoscopy is done. Or they may present because of necrotizing glomerulonephritis due to kidney involvement. Mostly the underlying etiologies are ANCA vasculitis, so ANCA is positive, and the anti-GBM, that is glomerular basement membrane disease. Acute respiratory failure requiring mechanical ventilation occurs in half of the cases, and bronchoscopy is necessary to exclude infection and to evaluate for the evidence of diffuse alveolar hemorrhage. So in these patients, it is very important to differentiate them from the common ICU presentations like sepsis, because they can mimic sepsis in many ways. The third important diagnosis, which should not be missed by the intensivist, is acute interstitial lung disease, which is connective tissue related, where non-specific interstitial pneumonia is the most common pattern, which is presented with HRCT, bronchoalveolar lavage, and serology for antibodies are critical to confirm the diagnosis. This usually progresses rapidly with ARDS setting in, and the mortality is there more than 50%. Corticosteroids are used as the first-line therapy, usually in combination with cyclophosphamide or mycophenolate mofetil. So we have to remember that in highly selected patients presenting with acute interstitial disease related to connective tissue related ILD, this ECMO may act as a bridge to transplantation. The fourth important entity which needs to be recognized is acute severe cytopenia. Now, when patients autoimmune diseases present with acute severe cytopenia, the hematological abnormalities are the common findings. Mainly, it is inflammatory anemia. If there is pancytopenia, that should be explored by bone marrow aspiration. And besides infections, drug toxicity, malignancies, and HLH. HLH is a very important condition which needs to be recognized early. And bone marrow necrosis, which is although rare, secondary to drug-induced or idiopathic. So these are the common specific findings which can be diagnosed by bone marrow aspiration. HLH is a life-threatening hyperinflammatory state which presents with high fever, hepatosplenomegaly, bicytopenia, that is fall in the counts across two different cell lines, and the presence of activated macrophages in the hemopoietic sites, which is identified by bone marrow aspiration. So we use a score known as the H score, and when this H score ranges from 0 to 337, and the probability of HLH is less than 1% when the H score is less than equal to 90, and the probability is more than 99% when the H score is more than equal to 250. In between, it is somewhere mixed picture. We have to correlate with the other findings. But this is a very important syndrome which needs to be recognized. The final fifth entity which needs recognition is the catastrophic antiphospholipid syndrome, which involves most commonly the kidneys, the lungs, heart, skin, liver, and the GIT. Even renal manifestations may occur with hypertension and acute kidney injury. And this is caused by antiphospholipid antibodies that activates the endothelial cells, platelets, and the immune cells which are present in the hemopoietic tissues and results in pro-inflammatory and pro-thrombotic manifestations. Usually, they are triggered by infection, surgery, or medication, and that can be easily identified by the intensivist. And it is important to distinguish them and differentiate them through biochemical tests from hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, DIC, and heparin-induced thrombocytopenia. So because they present a similar clinical picture, but the distinction can be made easily from the commonly available or the commonly performed tests. In all such cases, it is very important to look into the routine laboratory tests with a microscopic eye, with a detective's eye, because in the initial stage only, if we can miss the certain findings, salient features, then we can diagnose them early. Particularly when there is anemia, anemia can occur because of inflammation, it can occur because of hemolysis. So if you look into the peripheral blood smear, if you do a Coombs test, then we will be able to find out the cause. Or fix them along the flow chart. If there is thrombocytopenia, if it is alone, then it is frequent in SLE. If it is associated with anemia, then there are other causes like autoimmune hemolytic anemia, Evans syndrome, etc. If there is associated with leukopenia, then there can be rheumatoid arthritis. If there is pancytopenia, then there can be many other causes which can be found out by doing bone marrow aspiration with or without biopsy. If there is macrophage activation syndrome, then we have to rule out, besides these common conditions, lupus, Steele's disease, and juvenile chronic arthritis. And if there is bone marrow necrosis, then we will certainly have to focus towards the diagnosis of antiphospholipid syndrome and SLE. Likewise, renal function tests, we have to look for the blood pressure, creatinine, urea, urine dipstick. If the kidney syndrome diagnosis, if you look into the urine sediment, microscopic hematuria with presence of red cell casts and leukocyturia, then definitely it suggests the involvement of anti-GBM membrane, which is common in scleroderma and SLE. And if there is abnormality in the blood vessels, we have to go for a renal ultrasound likewise. Similarly, the inflammatory biomarkers, the muscle enzymes, coagulation tests, the liver function tests, all will give us a clue as to which investigations should be followed with. And once we know that, we can do the further investigations appropriately, depending upon the findings of the routine blood examinations or urine examination, which may include lumbar puncture to detect pleocytosis in SLE, in sarcoidosis, autoimmune encephalitis, etc. Elevated protein levels with normal WBC count, that is on acute and chronic autoimmune polyneuropathies, intrathecal hemoglobin synthesis in multiple sclerosis. What is more important is also to I understand the importance of lung bronchoscopy and bronchoalveolar, particularly when diffuse alveolar hemorrhage is suspected and alveolitis is presumed from the investigations, and also when to order imaging, appropriate imaging, because chest CT scan is done in most of the cases, but what is missed are the abdominal CT scan, which can show occlusion or aneurysm in Takayasu's disease or giant cell arteritis, etc. So whenever, if we follow a simple flow chart where if there is an atypical or unexplained organ failure, and after we have excluded pneumonia with anemia, AKI without recognized risk factor, and there is no response to empiric therapy, then we'll try to find out whether there is systemic involvement or not. We'll look for the clinical manifestations like personal history, family history of autoimmune disease, ethnicity, medications, nails, skins, eyes, do the routine blood tests, do a body CT scan or imaging of other involved organs, and exclude the differential diagnosis, particularly those related to drugs or substance abuse, infections like endocarditis, which are very difficult to treat, which have widespread manifestations and malignancies. Then we follow it with immunological workup and consider additional investigations like bronchoalveolar lavage or bone marrow aspiration. If feasible, we can consider organ biopsy of the involved organs like kidney, skin, salivary gland, etc. If we have to confirm flare-up, we need the help, support, and guidance of a multidisciplinary team, and the chronology of clinical manifestations, the unexplained inflammatory syndromes, the immunological manifestations, the symptoms grouping, everything has to be done so that there is equivocal diagnosis or a consensus diagnosis is reached upon. If we need to do the biopsy of the involved organs, it can be either the kidney, if there is glomerulonephritis with nephrotic syndrome, skin, if it is a leukocytoclastic vasculitis or IgA vasculitis, salivary glands, particularly in Sjogren's syndrome, sarcoidosis, amyloidosis, muscle in patients with suspected dermatomyositis or polymyositis, and other less common involves the lung, heart, brain, sural nerve, but these are more difficult, rare, and also associated with complications. But some tips which are very important and very easy to recognize and remember includes features in the hand. For example, if there are splintered hemorrhages on the tips of the fingers, which are longitudinal red-brown hemorrhage just under the nail, then that identifies that this patient indicates that they might be having antiphospholipid syndrome, SLE, Behçet's disease, or even that may be because of infective endocarditis. If there is Raynaud's phenomenon, it can be because of connective tissue diseases like systemic sclerosis, SLE, mixed connectivitis, or it can be due to vasculitis like cryoglobulinemia, giant cell arteritis, polyarteritis nodosa, etc. If there are ragged cuticles and nail fold redness, then that indicates the presence of dermatomyositis. Gottron papules also indicates dermatomyositis. Small joints arthralgia again involve rheumatoid arthritis. Hyperpigmentation indicates Addison's disease. Digital necrosis indicates connective tissue diseases or vasculitis. Similarly, the mechanic's hand, which is a scaly and fissuring hyperkeratosis, indicates antisynthetase syndrome, one of the rare connective tissue disorders more commonly seen in the Middle East. And of course, scleroderma hand with sclerodactyly calcium deposits and digital ulcers that are indicative of multiple sclerosis. Other than that, there are certain eye features which are also very important. Heliotropic rash that is seen in dermatomyositis, dry eye seen in Sitka syndrome, ptosis seen in myasthenia gravis, uveitis seen in Behçet's disease, sarcoidosis, psoriatic arthritis, Kawasaki disease, and multiple sclerosis, episcleritis seen in rheumatoid arthritis, SLE, Behçet's disease, and also in Crohn's disease, ulcerative colitis, and psoriatic arthritis. So these are simple things which can be easily looked upon, and if we can remember them, then we can guide the appropriate tests early. Immunosuppressive therapy, we all know, is the cornerstone of therapy, and that involves high dose of corticosteroids along with other immunosuppressive agents, methotrexate, leflunomide, etanercept, infliximab, adalimumab, etc. So in this case, definitely consultation with the rheumatologist and close collaboration with the concerned specialists are warranted, not only because there are variations in the indication of the drug and dosage, but also because the adverse effects and toxicities may occur early in some patients, and unless one knows them, they cannot be prevented. But certain general principles of drug treatment are there, like in ANCA vasculitis, cyclophosphamide is the most common cytotoxic agent which is used. IVIG may be used in critically ill patients who have concurrent severe infection. Plasmapheresis may be used as an adjunctive therapy to immunosuppression in patients with rapidly progressive glomerulonephritis. For SLE with life-threatening organ involvement, corticosteroids with other agents like cyclophosphamide or mycophenolate mofetil should be considered early in the course of illness. And of course, since these diseases have remission and relapse, even in ICU, maintenance therapy may be required to avoid relapse and spare steroids, particularly methotrexate, azathioprine, and mycophenolate. Therefore, intensivists should be aware of the treatment-related complications as well as the contraindications of the individual drugs which may be pertinent for a particular patient. So finally, my take-home message would be that autoimmune diseases are rare. But even though they are rare, 1/10 of them may present in the ICU because of flare-ups or because of multi-organ failure. Many conditions could lead these patients to the ICU, and these diseases carry a high morbidity and mortality in contrast to the other diseases, in particularly for infections which are complicating immunosuppressive therapies and disease flare-ups. So intensivists should keep a high index of suspicion in patients admitted with several but not fully explained organ dysfunctions, because whenever they are admitted, usually organ dysfunction has already set in because of the long period of illness. The treatment is no doubt complex. It requires multidisciplinary collaboration. It is not the job of the intensivist alone to remember the specific therapies for each and every connective tissue, which will have variations in their treatment. But it is too important that we have to give steroids and we have to give immunosuppressive management and also continue life-sustaining therapies till the patient gets responsive to the treatment. Thank you very much.